Hello, I'm Dr. Klaus Gottlieb. I will be talking to you about endoscopic ultrasound and giving you a survey of typical applications. Endoscopic ultrasound is the combination of an endoscope with an ultrasound transducer, which allows us to see organs which are normally quite hidden, such as the pancreas, with very high resolution, and also allows us to take biopsies. There are two scopes available. One of them has a radial imaging plane, seen here, which is good for general orientation and for cancer staging, and this instrument here with a curved linear array transducer allows us to take biopsies with a fine needle aspiration needle, which is in the sector of the crystal here. The indications of endoscopic ultrasound are ever expanding, and if you want to stay current, do a Google search, type in EOS and indications. Currently, one of our prior talks will be the first hit. EOS indications are typically staging of esophageal, gastric, and rectal cancers, the evaluation of abnormalities of the gastrointestinal wall or adjacent structures, such as submucosal masses, extrinsic compression, the evaluation of thickened gastric folds, the diagnosis by fine needle aspiration biopsy and staging of pancreatic cancer, evaluation of pancreatic abnormalities such as suspected masses, cystic lesions, including pseudocysts, and suspected chronic pancreatitis. Furthermore, staging of ampullary neoplasms, diagnosis and staging of cholangiocarcinoma, the evaluation of suspected choledocholitis, also celiac plexus neurolysis for chronic pain due to intra-abdominal malignancy or chronic pancreatitis, and lung cancer diagnosis and staging. The following cases will illustrate all these different indications one by one. Let's start. First of all, let's review the T&M staging system. Esophageal, gastric, and rectal cancers are staged with the T&M system. T stands for tumor, N for lymph node, and M for distant metastasis. This here shows a stage 1 or a T1 carcinoma, which is limited to the mucosa and submucosa of the colon or small bowel wall, is in this case. A T2 cancer would involve the muscularis propria here, but without traversing it. A T3 stage would be traversing the muscularis propria, and then a T4 cancer would involve an adjacent organ. For example, in the rectum, it would be the bladder or vagina. Here are lymph nodes. In these cases, they are not involved, and here these green lymph nodes are positive for metastatic cancer, so this would indicate a nodal stage of 1 or 2 depending on how many lymph nodes and in which location are affected. This is an endoscopic ultrasound of a gastric cancer. Here is the transducer. These are artifacts. This is fluid in the stomach. This is the gastric wall here. And very importantly, we see the typical wall layers of the gastric wall as seen by endoscopic ultrasound, consisting of a bright layer followed by a dark layer, another bright layer, and a very important second dark layer, which represents the muscularis propria. This hypoechoic tumor is a gastric adenocarcinoma, but as you can see, it's limited to the mucosal layer and barely invades into the submucosa. It clearly does not involve the muscularis propria. The endoscopic ultrasound staging of this tumor was verified at subsequent surgery. This is another staging example in the GI tract. In this case, we are now in the rectum. Here you see a large excavated rectal cancer, which is also in the center. This is the corresponding endoscopic ultrasound image, which shows that this tumor invades into the muscularis propria, but without traversing it. This was staged as a T2, and since there was no lymphadenopathy at the time, is an N0, rectal adenocarcinoma. Unfortunately, we saw this patient again 4 months later. In the interim, nothing had happened. The patient had refused conventional treatments, had seen a naturopath instead who recommended tea enemas and a number of other things. As you can see, in the interim, the tumor has progressed. Now you see typical tumor pseudopodia, which are traversing clearly through all wall layers of the rectal wall, making this now a T3 stage. And in addition, at least one lymph node is seen. There were more, but the images are not available here. So we have the progression over 4 months from a T2 and 0 stage to T3 and 1. Endoscopic ultrasound is the preferred methods to evaluate abnormalities of the GI tract wall. The reason for this is that there is a correlation between histology and endoscopic ultrasound appearance. The following correlations can be made. On endoscopic ultrasound, the first layer, which is bright or echo-rich, is actually a border echo. It's part of the mucosa. The second layer is dark and also belongs to the mucosa. The third layer on endoscopic ultrasound corresponds to the histological submucosa. And the fourth layer, which is again dark or echo poor, corresponds to the muscularis propria. This is such an abnormality of the gastric wall, a submucosal mass, in this case a submucosal gastric tumor. Here we see normal gastric folds, and here is a submucosal mass with a relatively normal appearing overlying mucosa. In the center is a small ulceration. On endoscopic ultrasound is again the transducer. This is water in the stomach, the gastric wall, and here we can see a hypoechoic mass, fairly well circumscribed, which connects here clearly to the muscularis propria. In other words, this is a fourth layer tumor which is well circumscribed and hypoechoic in the stomach, in all likelihood a gastrointestinal stromal tumor. This is a patient who had another submucosal abnormality which required evaluation. This was a patient with an operated stomach. At the gastroesophageal junction, a submucosal mass of this type was seen. It was not clear what it was. Fortunately, we did not biopsy it, because on a subsequent endoscopic ultrasound it turns out that this was an isolated gastric varix. Not exactly sure what the etiology is. Nevertheless, here we have a very big submucosal vessel, which with the spectral Doppler actually turns out to be connected to the portal venous system. This is the typical and characteristic spectral Doppler signature of the portal vein or the portal venous system, and so it was prudent not to biopsy it and leave it alone. Thickened gastric folds have numerous etiologies. Frequently they're just seen on a CT scan, and actually, as it turns out, when you look with endoscopy or with endoscopic ultrasound, everything looks fine. But let's assume they are really truly thickened. They are hyperacidic states which can do that. For example, Zollinger-Ellison syndrome, hypoproteinemias, lymphomas including mild lymphomas, eosinophilic gastroenteritis, varices, Menetrier disease, Crohn's disease, and a number of others. For example, infiltrative disorders like rhinitis plastica. This is a case of rhinitis plastica. On a CT scan, it's obvious that the gastric wall is thickened. And then on endoscopic ultrasound, we see this much increased mucosa and submucosa. Looks very fluffy, and it's about 14 millimeters here, and there's another 3 millimeters of muscularis propria. Very, very characteristic. As you know, it's really hard to get diagnostic biopsies because the tumor cells are mostly located in this layer, and you don't get deep enough even with big biopsy forceps. It may be difficult or impossible to get a diagnosis, and often a full thickness biopsy is required. But if you have this appearance, that's enough to refer the patient for laparotomy if this is what you want to do. This is another case where we have relatively mild thickening of the mucosa and submucosa, but it occupies approximately 50% of the total thickness of the gastric wall, which is also not normal. And the reason for this was the mold lymphoma, which you can see here. There's a very dense infiltrate of all these blue cells, which are neoplastic monoclonal lymphocytes. A lot of our referrals are made for diagnosis and staging of pancreatic cancer. Often we only initially see the smoke of the fire, in other words, a sign, an indirect sign that there might be a mass or an abnormality. And one of the more useful signs are periduodenal collaterals, which are not really expected because the patient doesn't have portal hypertension. Here they are seen on a radial endoscopic ultrasound. Here's the transducer again in the duodenum, and here are these serpiginous tubular structures which turn out to be venous collaterals, and this is a color flow Doppler. The cause for these periduodenal collaterals in this particular patient was the hypoechoic mass shown here. We are looking at basically the pancreatic neck area. Here's the pancreatic body and tail region. Here's a dilated main pancreatic duct. That's the splenic vein. And this is the aspect of the same tumor with linear array ultrasound. The dimensions are given here. It's 2.6 by 3.1 centimeters. Another interesting pancreatic mass in this patient. This was a approximately 50-year-old woman who had a diagnosis of Gardner syndrome or familial adenomatous polyposis, and I'm not sure for what reason the CT scan was done. In any case, here was a small, very small mass in the tail region of the pancreas, and not inappropriately it was decided to watch and wait and get another CT scan 3 months later. And 3 months later, this little mass has grown into this much bigger mass, indicating a very rapid growth, which may be related to the underlying genetic problem. But on endoscopic ultrasound, this is the way it looks on the radial scan. And here, fairly dark, the appearance of that same mass as taken with the biopsy curved linear array instrument. The biopsies were positive for adenocarcinoma. The patient had surgery, and it turned out to be a T1N0 lesion, so she is expected to be cured. Now there's lots of other pancreatic abnormalities which can be evaluated by endoscopic ultrasound. For example, chief of them, pancreatic pseudocyst. This was a patient who did have some pancreatic calcifications and an ill-defined mass on CT scan, which was hard to further characterize. This is it, and here on endoscopic ultrasound becomes quite clear what this is: an organizing pseudocyst with lots of debris and septations inside. This particular patient also had a small duodenal pseudocyst, not shown. Now this is chronic pancreatitis, and you see there's numerous calcifications here in the head of the pancreas intraparenchymally, but also there's a large stone blocking the main pancreatic duct. Maybe in this image you can see it a little bit better. Here a stone with a typical posterior shadow. Here are intraparenchymal calcifications. There is a dilated pancreatic duct. Obviously this patient cannot be cured, but as you know, oftentimes treating these obstructing stones which lead to an upstream obstructive pancreatopathy may improve their pain. and this patient was subjected to extracorporeal shockwave lithotripsy, which took care of the stone. It just had to be removed. The pieces had to be removed during ERCP, and the patient was doing better until fairly recently. Now, fatty infiltration of the pancreas is, I think, a topic which doesn't get a lot of attention. We always talk about chronic pancreatitis and the criteria of chronic pancreatitis. As you all know, there are a number of them, but I want to focus here on this particular patient. Initially, if you don't pay too much attention, you think there's lots of hypoechoic foci, but when you look closely, and also with higher ultrasound frequencies, you see this lobulated appearance and a septa of fat going through the pancreas and giving it a marbled appearance, lobulated appearance. So this is not chronic pancreatitis, it's just fatty infiltration. This was a patient who was suspected to have a pancreatic adenocarcinoma with a fairly large mass in the pancreatic tail region. Here is the coronal reconstruction of the CT scan, shows the same mass. It turned out to be a benign adrenal adenoma. Normally we try not to biopsy adrenal masses unless we want to make a diagnosis of metastatic disease, because, as you know, small adrenal masses are most of the time benign adenomas and can be watched. But once you get to the 4 centimeter size range, you start worrying about, could this be something else, even if it looks benign, and a lot of physicians recommend at this size to refer for surgery. Now, once we knew that this was an adenoma and not a pancreatic cancer, the patient waited a little bit, but they finally decided to have surgery, and the diagnosis of a benign adrenal adenoma was confirmed. Interestingly, our colleagues often don't know that we can biopsy adrenal masses fairly easily, and there's certainly some indication which still needs to be done. Endoscopic ultrasound is also a very good modality, or maybe one of the better modalities, to evaluate ampullary neoplasms. Just to remind you of the anatomy, here's the bile duct and the sphincter Vodi, which actually has 2 components, a very small one, smaller circular muscle in the pancreatic sphincter segment, and a much larger one in the bile duct segment, and then obviously here the external papilla. This was a patient who was referred after he had been diagnosed with sphincter Vodi dysfunction, but somehow the lab test abnormalities came back, and this ERCP done by somebody else shows a fairly bulbous termination of the distal common bile duct. On endoscopic ultrasound, you see that bile duct diameter and pancreatic duct diameter are approximately equal, so the main pancreatic duct is dilated. The bile duct is also prominent, but not necessarily big. But here is a hypoechoic mass over the papilla. Here you can see that a little bit in a different aspect. This is the endoscopic appearance of this papilla, which looks quite abnormal. Biopsies came back as showing adenocarcinoma. This is a patient with recurrent pancreatitis. Interestingly, he also has a history of familial adenomatous polyposis, but he's much younger. He had 2 attacks of acute pancreatitis of unknown etiology. He had undergone surveillance, upper endoscopies, and nothing much was found. But here is an ampullary adenoma. Biopsies showed villus adenoma only, and here on the endoscopic ultrasound you see a isoechoic mass which has a little tissue plug going into the main pancreatic duct, probably explaining his recurrent pancreatitis as an obstructive phenomenon. And he went to a surgery and had just this removed, resected, without having to undergo a Whipple surgery, because the frozen section didn't show any tumor. I mean, at least no cancer. It was just a villus adenoma. And which leads us to a topic of cholangiocarcinoma, which is a difficult diagnosis to make. especially in the setting of primary sclerosing cholangitis, where you have strictures which are by and large benign, but then occasionally you get a stricture which kind of becomes malignant, and endoscopic ultrasound can contribute to the evaluation of these patients. But as you know, only recently, with the advent of cholangioscopy with the spyglass equipment, do we have another instrument or another modality to specifically evaluate cholangiocarcinoma. Nevertheless, endoscopic ultrasound remains a very valuable component of the overall workup. This is a patient who had a cholangiocarcinoma, which you can see here as bile duct thickening. Here you see a normal distal common bile duct and a normal pancreatic duct converging towards the level of the papilla. And here is a thickening and a hypoechoic tumor, shown here in this insert one more time, and we see that quite nicely. This is another cholangiocarcinoma, a little bit bigger. This is the ESCP appearance with a fairly long stricture, normal bile duct here, upstream bile duct dilation. Here's the scope. The gallbladder is shown here on the endoscopic ultrasound. Here is thickening of the bile duct on the endoscopic ultrasound, and moreover we also see a large periportal lymph node, which may or may not be malignant. I don't remember whether we biopsied that at the time or not. Another indication for endoscopic ultrasound are common bile duct stones, or at least the suspicion of common bile duct stones. If you have a high index of suspicion, the patient would probably straight go to ERCP. But if there's an intermediate or low probability, especially if the patient would suffer greatly if they would get post-ERCP pancreatitis, or he can't afford that easily, then checking with endoscopic ultrasound whether stones are really present is probably the way to go. The sensitivity of endoscopic ultrasound for the detection of common bile duct stones is at least as good as ERCP, if not better, and a lot of people in the ultrasound field think it's probably better than ERCP. Now this is a no-brainer, so to speak. This is a big mass, and most people thought it was really a stone, which it turned out to be. You see this here, and then the hypodense bile duct dilated in this reconstruction. That's very nice. You see the dilated bile duct, and then here a mass or stone. And indeed, on the endoscopic ultrasound, a big stone was seen, which had posterior shadowing, as you can see here, and another view of the same stone. The patient subsequently had an ESCP. Here you see the stone again, outlined with the dye flowing around it, and here the stone pulled out of the bile duct after a biliary sphincterotomy. Another indication for endoscopic ultrasound is injection therapy. The most frequently performed therapy is celiac plexus block, either with a local anesthetic, temporary or diagnostic, or with a neurolytic substance such as alcohol or maybe phenol. Here's the plexus around the arterial system, and here are the nerve ganglia. There's a left and right celiac ganglion located to the left and right of the celiac artery. We have new needles which allow us to diffuse the substance to both the left and right without having to address these two ganglia individually. Endoscopic ultrasound also holds great promise for tumor therapy, where we basically use our fine needle aspiration capability to direct therapeutic substances into tumors. Right now we're quite limited, and still the studies going on with a number of different substances, but on a compassionate basis we have in our praxis used alcohol in this patient or others where there was, for example, a extrinsic compression of the esophagus from a tumor metastasis. In this particular patient, there was widely metastatic ovarian cancer with mediastinal pleural metastasis leading to the compression of the esophagus. The patient had maxed out radiation and chemotherapy, and nobody wanted to do anything in that direction. We talked to her and we decided to inject alcohol under endoscopic ultrasound guidance into the tumor. And this was the tumor before injection, measuring about 4.4 centimeters in largest dimension. Here's the esophagus, here's the transducer. The tumor kind of buckles into the esophagus. After alcohol injection, like a week later, there is a sliver of pleural fluid separating the tumor from the esophagus, indicating that the tumor doesn't push that hard anymore. Otherwise you wouldn't see that. And also the dimensions have shrunken to 3.7 by 3.6 centimeters. Clinically, this was associated with a good palliation of a dysphagia. Lung cancer is a very important and unfortunately still emerging field for endoscopic ultrasound. We are able to obtain biopsies, first to diagnose lung cancer and secondly to stage it. And we don't have enough time to go too much into detail, but suffices it to say that endoscopic ultrasound is a preferred modality for subcarinal lymph nodes, area 8 lymph nodes, here paraesophageal, and area 9 lymph nodes. We can also frequently obtain hilar lymph nodes, especially those located on the right side, on the left side, and we can obtain samples from the aortopulmonary window lymph nodes, which is area 5. Now, endobronchial ultrasound is a very promising modality which, together with endoscopic ultrasound, probably can obviate the need for mediastinoscopy altogether, and probably is better and can do more than mediastinoscopy could ever accomplish, with much less invasiveness, without going to the OR, and with conscious sedation for the most part. Just to remind you, there's a American Thoracic Society lymph node map, which is given here, and these are the lymph node stations. And this here, the area 5, aortopulmonary window lymph nodes or subaortic lymph nodes, are a very important lymph node station, which previously could only be accessed by a mini thoracotomy, the so-called Chamberlain procedure. But with endoscopic ultrasound we can easily see this here. Now, this is a patient who initially presented with this lung cancer here on the PET-CT fusion, and he had surgery and presented unfortunately 8 months later with a subcarinal lymph node mass, which was successfully biopsied with endoscopic ultrasound guidance. This is an area 7 or subcarinal lymph node. Here's the lymph node, here's the needle going into the lymph node, and the biopsy showed non-small cell lung cancer recurrence. I'd like you to keep in touch with our practice. If you forget our phone number and so forth, just type in EUS Spokane and our practice information should come up. Thank you for your attention.